So one of the things that I want to talk about, again, my name is Kojo Hamilton. I'm from University of Pittsburgh School of Medicine and Medical Center, is topics that are near and dear to me. I'm going to be giving a lot of pearls in avoiding pitfalls in cervical deformity surgery. Now, this is a past lecture that I gave last year and about a couple of years before. This is more of a continuation of that lecture. It was more of a basic lecture, and I'm going to go, at that point, if you're going into the archives of SSF, will be the cervical deformity and its implication on spinal balance. During that time, we asked questions such as, are there fully established cervical deformity classification and treatment options? And are there defined indications for surgery to correct cervical malalignment? And are there set standards to address the amount of correction needed? And what is the impact of the regional cervical sagittal alignment on outcomes? It's quite impressive. During that preamble talk, I talked about the cervical spine needed for maintenance of horizontal gaze and also the centers of mass, but really also biomechanical stability into three columns. One anterior column involving the vertebral bodies and disc. You guys are familiar with that, and the posterior columns. And also its load sharing compared to the thoracolumbar spine. And why the lordotic cervical spine, because of the compensatory thoracic kyphotic region needed for lung expansion, and it also increases with age. Now, the prevalence of cervical deformity is quite high in patients that have thoracolumbar deformity. It's always something that you have to look at. And you're well aware of the high degree of motion and also in the upper cervical versus the lower cervical spine, and hence any fusion as you saw in the upper cervical spine may have more consequences if the lower cervical spine or subaxial spine does not have much motion. So there is disability related to cervical spine pathology. There's no question about that. Breathing, swallowing, myelopathy, radiculopathy, and also there are now recognized global compensatory mechanisms in alignment related to what we do in the cervical spine. So there are repercussions in terms of the loss of cervical lordosis and also the other degeneration and the poor chain reaction. Here you see a normal cervical spine. In a hyperkyphotic kyphotic cervical spine, you do have compensatory mechanisms in column B that accentuate the patient's pain and misery, as well as if they're hyperlordotic as well. This impact of cervical deformity continues to be quite prevalent. It's sort of the added burden of misery to the patients with regard to the daily activities of living. The other issues has to do with the cervical sagittal malalignment that we talked about in the other course, or should I say my other lecture, which increases patients' disability with regard to physical and also with neck pain. So an example would be somebody who shows up routinely in my clinic, 68-year-old female with difficulty with horizontal gaze, severe neck pain. She also has late afternoon back pain. She has no arm pain. She has some left shoulder pain, which she thinks might be a prior tear, a rotator cuff tear, and she quit smoking 7 months ago. Question is whether she's osteopenic or not. So this is the FlexX imaging that I obtained, but then you look at a global alignment, right? That's what I'm trying to stress with deformity. Nothing is segmental. Look at global alignment. Look at how back looks like, the coronal and sagittal deformity. What's contributing? What are the pain drivers? What kind of exams are you going to do? The cervical spine cannot be evaluated as a standalone region for any deformity, no matter how mild. And I stress this because I would like people to have global films when you're dealing with non-focal deformity, right? So if you feel like you're going to do a long construct, it'll behoove you to look at it in totality, right? So one of the things that I'm looking at a lot in my clinic, quietly and sometimes verbally, is the cervical lordosis, T1 slope minus cervical lordosis. It is the PILL mismatch in the thoracolumbar spine equivalent. If you have a small T1 slope, you need very little cervical lordosis to maintain your center of mass and alignment. An example would be an iatrogenic, in the first column, iatrogenic large T1 slope will require significant alignment to maintain, significant compensatory C2, C7 degrees to maintain the balance that's required versus in a smaller slope where you even have kyphosis in the cervical spine, you need less to maintain alignment. And another issue that I always want to see is if anybody's had a lumbar fusion, thoracolumbar fusion, I want to see how it affects their cervical spine. And you can see the gradual deterioration of a patient after a thoracolumbar long construct surgery. They extended it a little. It makes her cervical alignment worse. And now we have to go all the way to the top. And this is just the natural, now we understand, compensatory reaction to any surgery that we do. And some studies have shown that if we don't get it right the first time, it exacerbates this situation. So are there fully established cervical deformity classification and treatment options? You guys are going to be the bastions of wherever you take a job as the deformity surgeons there. And yes, there are. I personally use a simpler classification, the AIMS ISSG classification. And really, it starts with a deformity descriptor: cervical thoracic, primary thoracic, and also coronal versus cervical craniovertebral junction deformity. And then the other modifiers. I do this calculation in my head in clinic. I may write them down. If you're a fellow with me, I expect you to start doing these calculations in clinic, mostly because it's going to guide what we do, and it gives you a plan as to what's really important, how do we negotiate pain drivers, and also an alignment. Several studies have shown how this improves, and there's a strong clinical correlation with that, and a good strategy to have a cervical deformity classification system to help you with. Let me give you an example of a few deformities that you encounter, right? You have a flat neck, either rigid or mobile. Patient may have a focal kyphosis with some anterior listhesis, or even a cervical thoracic deformity, or one of my serious concerns with a concomitant coronal deformity. That's the hardest to treat. That's what I always look at and say, we are going to need a co-pilot. When I'm ever doing anybody with a coronal deformity in addition, I'm looking for a co-pilot, co-surgeon to help due to increased dislocation of the spine required. And really, it's very important. I also then go back. If you go back, we only showed you the cervical spine. I want to see how that's in relation to the rest of the spine. And then in clinic, right, we're trying to avoid pitfalls here. We've seen the images, we've examined the patient, taken a history, we've seen the images, but we're going back again to say, how do they look when they stand? What's their burden, right? We want to see what are we correcting in the actual musculoskeletal jacket and patient's compensatory factors. I also have them lie down in the clinic and say, how are they able to cope? I support the head where the arrow is pointing. I support the head and say, why don't you relax and let me know where your head lies? It lets me know how rigid, etc. things are. You can also have them go downstairs or to the side and get x-rays. But I really want to see for myself to make sure that when they go down to get x-rays, they are not artificially manipulated. So I do want to see, what do I get here myself? So things to know in this day and age. It's not just the clinic. It's not just your exam, you have to think about cervical alignment or stretch, that there are repercussions to what we do, right? You all are residents and fellows, neurological injury, tracheostomy, things that you have to counsel patients with rigid deformities, anterior surgery, swallowing difficulties, and also vascular and soft tissue issues. So in addition to that, you have to also start counseling them about and also seeing what modifiable factors you can have with bone density, rigid deformity, like I mentioned, 2 surgeons are always better, and also with modifiable things. Now we have all these GLP-1 medications that could help if they're, as opposed to requiring people to quickly undergo bariatric surgery, and really nutritional status. I can't stress how that affects wound healing. So we have a plethora of surgical techniques. Anterior, I reserve that for mostly ACDFs, for focal deformities, corpectomies if I have to extend it, and to do osteotomies in a rigid spine for release, versus posterior where we do laminectomies, osteotomies, and 3-column osteotomies, or even intervertebral pedicle subtraction osteotomies. So we can always start with the progression of what we want to do. You can start from the first column of doing, and this is one of those things that are better explained in the lab. We have a cervical station where we could do facet releases and intralaminar releases for gentle compression as needed, versus total laminectomies, facetectomies, and clear osteotomies if we're going to compress. And then you have an option of doing an open wedge closure through a disc space versus intrabody pedicle subtraction osteotomy. These are techniques that I would implore you to practice. One of my greatest visions were seeing Dr. Chapman, after everybody's left the lab, going in to do his own personal dissections. And I said, wow, the learning never stops. So it's quite impressive. There's great opportunities for you to continue to do this today. And there are several techniques that will be enhanced in the lab that I want to go over, but some of the things that when you start your practice, you will be the top person there. Your partners will be sending you all their deformities, right? So I want to mention things like when we're doing posterior osteotomies, I want to see all the nerve roots all the way through. I don't want to leave an opportunity for nerve to be compressed by residual facets if we're going to think about closing on an osteotomy or closing a created deformity. So the second thing I want to talk about is avoiding buckling of the cord. If you have to do this, you have to really peel and skeletonize the scar tissue off and avoid buckling of the cord. Those are 2 of the main things that require you to come back, sometimes rather late, where patients have prolonged deformity. If you do any compressive maneuvers in any part of the spine, particularly cervical spine, patient wakes up with neuroradicalopathy, it's best not to say, oh, it's stretch, it won't go away. You got to have multiple modality imaging. This is very important. It won't go away. You have to check. If it's C5 palsy, verify with imaging, okay? So one of the things is secondary, an example that I'm going to quickly end with is mixed rigid flexible deformity that you're going to see. Example, ACDF in the front, wiring in the back. This is an old construct that you have to look at. So if we're going to fix this, patient shows up, severe radicalopathy, even within the construct that's been performed. This is natural order of time. This is an old construct. Degenerative process is not arrested. Then they also have anterior listhesis above the construct, severe neck pain, difficulty with maneuvers, and multi-level radicalopathies. So you know that their extent and effort. For my past lecture, you would talk about the extent and effort required to maintain your horizontal gaze alignment and also just your general a sense of well-being. So one of the first things when I see this is I need to do posterior releases. I need to get things removed and to see how much correction I can get. Most often I get lucky. I am able to do laminectomies, facetectomies, complete correction, scrub out, have my co-surgeon in the field manipulate the levo or Mayfield to see if I can get the correction that matches my preoperative alignment, et cetera. If not, we'll have to temporize with a temporary rod and then go anteriorly to do osteotomies, disc removal. And one of the things that I want you to take advantage of if there's an anterior cadaver is to really go into the disc space and go as far out in multiple levels. Where do I see the vertebral artery? And one of the things that I caution everybody is never start a cervical spine case thinking, oh, we're just doing 2-level ACDFs. You have to look at your MRI. You have to see whether this is a normal line vascular, what other issues are around the area where I'm going to operate on, because there are so many variants in the normal pathway of the vertebral artery, and it's surgery that, though routine, can end up being an all day with canceled sequela to the patient. So take your time. You're not going to have a preoperative imaging on the cadavers that we are doing today, but use the time to say, I want to see in a posterior spine, where will I encounter in the, between C2, C1 to C7, the vertebral artery? How far do I need to go? Give yourself a frame of reference today. So if you do anterior and posterior releases to take care of radicalopathy, I'll be putting bone graft in and be able to freely close the spine in the third stage. So when you do this, it's a front, back procedure. It's an all-day procedure. What am I not doing? What am I preventing myself? I'm a new attending, young attending. These days, all the hospitals say, you just graduated last month. They'll put a date of your graduation. You're going to have all these insecurities. You need your co-pilot, right? But you need to avoid negative persistence. That's, if stuff's happening, I have a CSF leak, it doesn't mean that today I must get through all my stages. I am literally making adjustments to my plan intraoperatively as things happen differently, right? Blood loss. If I have a vessel injury, what are we doing today? Are we coming back today, or we're making alternate plans? So you have to also know your co-pilot early. There's a typo. It's like KNOW. And you have to make sure that your co-pilot that you're choosing is up to snuff, right? You have to plan ahead. Know who, if you're doing big deformity, front, back alone, who's in the OR with you? You're new hospital. You present the case before the M&M, present it to your senior colleagues, externally to your fellowship directors. I try to do this because this is what sinks in. It's so easy to say, oh, I went to a nice course cadaver, we were taught this, but then when do you make that phone call back home? When do you call Dr. Chapman and say, hey, I've done this 5 times with you, but I just want to run things by you, right? Don't be on call when you're doing this. This is not a routine ACDF where you want to be paged incessantly or you can get through before. And try not to have overlapping surgeries without a co-pilot when you're doing deformity surgery. Vet your co-pilot before you do your front case. And you really have to be synchronized. You could just see Dr. Chapman and Dr. Sansor today in the cadaver lab. It just seemed like it was a dance, right? It was a 4-3-2-1 dance, as I call it. There's four hands in the wound. You could see when Dr. Chapman said, I need to hold this instrument with 2 hands. Can you tap for me? That's seasoned pro. This is one of his 10 commandments that you'll get familiar with at the end of the course, right? So 4 hands, 3 hearts, 2 surgeons' hearts, all pumping out the same with the patient, and you're doing manipulating one spine. So it's not a good idea to say, well, I'm in a new place, I'm the new academic person, I'm going to do this with a chief resident or super chief or fellow. if we're talking cervical deformity, front, back, things that I've shown you, you have to have somebody helping you. I truly believe in that, okay? So you have to also prep the patient, right? Bone quality, habits that are modifiable, multiple patient visits before you engage in this. And some of my partners are even having patients undergo neuropsych testing to document. Don't be shy about letting them get a second opinion. Meet your co-pilot, prep them in clinic. And like I said today, get in the lab, go beyond what we're saying in the lab to say, I want to see this. You want to avoid negative persistence. But really, you have to always think about how the patient is compensating in their cone of economy. Thank you. Questions?
That was wonderful, thank you. Of all the things that you showed, there are so many nuggets in there. I really liked your emphasis on the clinical exam.
Yes.
I think we both think alike. It's very annoying for the audience, but so cool to see this kind of a positive independent reinforcement.
Yeah.
I think when I see a crooked patient, I want them to be laid flat on their back. I put my hands under their head, and there's a question coming in a second, and their legs stretched out, check for hip flexion contractures, knee flexion contractures, see whether they can relax the head, see whether the SCM is tight, contracted, whether the torticollis can be released or not. The key problem for me is always if they can't get the head done. I use my fingers as a gradient, so maybe we can publish that together, how to assess that. But
excellent.
if a patient does not get a level head or within a couple of finger breaths to their base plate, their base couch or exam table, what does that do to your surgical planning? Do you still go anteriorly if you have a very contracted chin-on-chest deformity? Do you still go anteriorly somehow, or do you do a posterior shortening osteotomy? What does that do to your surgical planning?
One of the things that I'm always worried about is if they have, if they don't have all of the lower limb issues, is to make sure that they don't have a turtle shell of a thoracic kyphosis when they lie down. If not, then I'm very keen on doing a posterior shortening surgery to realign them. And unfortunately, a lot of them will need also anterior release as well. So.
And the second question, I've had struggles, and I'm very careful how I retract anteriorly with contracted necks, and I straighten them out with dysphagia, so swallowing difficulties afterwards. I frequently will give, especially the more emaciated patients, preoperatively PEG tubes. Is that something we should consider? What do you do in terms of making sure that they get adequate early nutritional support?
So for those that are really emaciated, I typically want to make sure that if they even have a modicum of swallowing function, is to do aggressive preoperative nutrition. And my concern has to do with post-op with the dysphagia, to start first with a tube, a nasal tube, and then go forward with that. Sometimes we're seeing it less and less due to disease-modifying agents, but people with severe rheumatoid, severe arthritis disease, I think once now, it used to be at least twice a year, but now I'm restricted to maybe once every 3 years to get them a PEG tube. Questions at all? All right, I think we have a